Thank you and welcome to this special I3 session, AI Under the Hood. We are faced with a plethora of AI papers recently, and it is this webinar we will discuss the practicality of using AI in the IVF lab. I'm joined with my colleague, Dr. Irene Dimitriadis. You can read her full bio on the site, but her most recent research is geared towards understanding and applying the use of deep learning AI technology in ART, with the goal of individualizing patient care and improving ART outcomes. And Olcay Ocali, who's our friend from up north of Boston, who is an embryology supervisor at Boston IVF, where he performs all aspects of embryology and gives training on micromanipulation such as ICSI and embryo biopsy. Again, you can go to the site for more information on Ocali. Today's webinar is kindly sponsored by IVF 2.0. Thanks for joining us. I encourage you all to please ask your questions using the Q&A section of the conference service and not the chat function. So definitely go to the Q&A section and don't use your chat, otherwise we may miss your questions.
Great, thanks, Charlie. Dr. Charles Bormann is a reproductive physiologist by training and the director of the Assisted Reproductive Technology Laboratory here at Massachusetts General Hospital. It is a pleasure to work with him, and it's been a pleasure working with him throughout our research projects as well. It's also a pleasure tonight to be co-moderating alongside him and Giles Parmo, who is known from I3 and Lizette and Olcay as well. So as far as Lizette is concerned, she's a rising star in embryology and a laboratory supervisor of OMA Fertility in California, with pretty much firsthand experience of AI in the laboratory.
Okay, without further ado, let's hear from our first speaker, Jacques Cohen, synonymous with lab technology and innovation. His full bio and long list of accomplishments you can find, yes, you have guessed it, on the website www.ivfmeeting.com. This introduction to this topic is pre-recorded, but he will be joining us later in the webinar to answer any questions.
Thank you very much for your kind introduction. It's my pleasure to talk to you today and give you a very brief introduction to the fantastic subject of artificial intelligence in reproductive medicine and lessons from other disciplines in medicine. I have several conflicts of interest, potential conflicts of interest, and those are listed on my bio on the I3 website. And for the purpose of this particular presentation, I am a co-founder of IVF 2.0. So what is artificial intelligence? Well, in the literature, there are a lot of different definitions about it, but it really comes down to this. It's the ability of a computer or a robot connected, controlled by one or more computers to do tasks that are usually done by humans because they require human intelligence and judgments. In the case of embryology, maybe even dexterity. So that's really what artificial intelligence is. It's to take over certain tasks from us or assist us with certain tasks. Who started this? Well, Alan Turing started this. And he probably had already thought about the concept in the 1930s, but his first lecture about it was after the Second World War. He was already a very well-known person. He had introduced the concept of computers, and in the Second World War, although maybe that was still a secret, he had cracked Enigma code, the German Enigma code. And he mentioned computer intelligence for the first time. And this is what he said. What we want is a machine that can learn from experience. What we also want is the possibility of letting the machine alter its own instructions and provides the mechanisms for this. So he introduced the concept in writing in a paper called Intelligence Machinery a year later. Now, who coined the term artificial intelligence? That was Professor John McCarthy from Stanford University in California. He coined the term AI in 1955, preparing for a meeting on artificial intelligence. And basically is what he said: every aspect of learning or any other feature of intelligence can in principle be so precisely described that a machine can be made to simulate it Really, very, very well put, very articulate. So do we have AI already? Oh yeah, we have lots of AI already all around us. Everything we do is almost affected by AI. Of course, everybody thinks about self-driving cars, but that's only really the beginning of it. Self-driving cars I'll come back to later. Instant translation, it's involved in transportation, in GPS. It's involved in your smartphone, in almost any aspect, and not just in the interface. Ride-sharing apps like Uber and Lyft and others. AI autopilot. Autopilots exist already for more than 100 years, but they're really controls that have been set and are controlled for only one set point, such as speed and velocity. Spam filters, plagiarism checkers, robo-readers, check deposits, fraud prevention, credit decisions, and of course, social networking. It's all over the social networking platforms. And this particular presentation from Microsoft's PowerPoint for Apple, this particular presentation is also done with using a lot of AI. All the slide designs have been done with AI, and it's become a little bit messy just to illustrate what the AI does. And also most of the fonts that are used here were built by AIs. First, a few words about terminology. When you get a new field like artificial intelligence and mathematics joining with the field of reproductive medicine, you get a lot of inspiration, a lot of creativity that comes out of it. And one of the things that, of course, always happens when that occurs, and the last time, or one of the last times, was with genetics and preemptive genetic testing, you get a lot of terminology, and it can be really confusing for the users who are using the new technology. So fortunately, one of our moderators, Irene Dimitriadis, and also two of the other speakers today and moderator today were involved in this paper that was published in RBM Online last year on the artificial intelligence in embryology laboratory, a review. And on table 1, which is on the second page, there's a glossary of terminology, which is really fantastic. And here you can see the entire table, which I'm sure you can't read because I can't read it just standing right next to it. But I suggest that you print get this paper, print it out, and print out table 1 separately and put it on your computer desk for the next year or so to get used to the terminology that's being used. So AI in medicine, well, that's not a new concept entirely. It has already been attempted or used since the 1970s. It wasn't a fantastic success, and it was only used by certain people, more or less pioneers, if you like, who would use this in their medical environment. So expert systems were developed in a variety of fields of medicine and encoded knowledges such as mycin, which was a test which was used for looking at bacterial infectious disease. Mycin is still used nowadays, and nowadays it's affordable and works well. In the 1970s, it was, I think, developed in 1977. It was very costly and very difficult to install because networks were difficult to install and the computers were very expensive. So why the recurrence of artificial intelligence in the last 5 to 10 years in medicine? Why is that happening now? Well, one major reason is reduced costs and rapid progress, particularly in the branch of machine learning. And also in the aspect of big data. Big data, of course, always existed, but not in the way it's existing now, and not in the way that we can actually handle big data now and can manipulate big data. So the ability to catch data early on was often overlooked in the 1970s and 1980s. And so artificial intelligence has come roaring back, and there's particularly incredible progress in medical imaging and computer vision. And AI experts often talk about narrow AI, that is an AI in computer vision that can do one task, can recognize one form really, really, really well. And it does that so well, it can do it as well as humans do, maybe even better. And so I think the next few talks will illustrate narrow AI and how well it can work. Now, recent studies show narrow machine learning imaging algorithms may equal and in some cases surpass human performance. In 2016, researchers in Boston reported that an AI-powered diagnostic program correctly identified breast cancer pathology slides at a rate of 92%. It's really fantastic. The trained pathologists, of course, did score higher at 96%, but combining those two methods led the trained pathologists to increase their accuracy highly significantly to 99.5%. Now, these studies like this have not yet been conducted in IVF. We hope that they will be conducted, but artificial intelligence started a little later in our field. Not entirely sure why that is, but certainly one reason, again, is probably funding. You do need some funding to do these studies and to do randomized clinical trials, particularly in the United States. You would do a lot better if you had government support, and there is no government support for anything between fertilization and implantation in the United States. So it's hard to do these studies, and it's particularly hard because of the nature of the field where we are in. Now, one of my heroes is Eric Topol. You see a picture of him here. Eric Topol is a professor and researcher, a doctor also, who's still practicing at the Scripps Institute in California, in La Jolla, the Scripps Institute, which is a part of the University of California in San Diego. Now, he published a book in 2019. He's very much interested in artificial intelligence, and he published a book on AI, and it's called Deep Medicine. I highly recommend that you read it. It is very complete, and therefore, even if you listen to the audiobook, it would still be more than 11 hours. So it's about how artificial intelligence can make healthcare human again. There are, however, a couple of papers that he wrote at the same time, and one of those I've used that was published in Nature Medicine by Eric Topol, and that gives a good review of the application of AI in medicine. And in figure 2 of that particular paper, you see the timeline all the way on the left from embryo selection for IVF, which at the time when he wrote that paper were the first few papers that were being published in our field, all the way to predict death in hospital and promotes things like patient safety. And these examples of AI application across the human lifespan, it's getting richer and richer and more populated with applications in this timeline. So it's all the way from assisted fertilization now to assisted living and beyond. In figure 5, he does an important analogy between self-driving cars and medicine. In self-driving cars, there have always been 6 areas where AI experts are saying, you now have gone to the next phase of automation. The first level is level 0, where there is no automation. And that, of course, you also have a medicine. If you go back to 1980, there was no automation. Even in 1990, there was very little automation. So now we have gone into level 1 and level 2. In the case of the car, driver assistance, such as speed control, interactive cruise control, as it is called, as well as lane keeping. And so we're somewhere in driving a car between level 1 and level 2. So the level on the right, where you have automation involved at a high degree, and in the last final level, complete autonomy, where you just go into the car and the car drives by itself anywhere you want, under any conditions, on the road or off the road. Now that is maybe achievable, but a lot of people think it's unlikely. And that's the same with when you look at the analogy with medicine, where Topol says that level 4, where there is minor supervision by medical experts, that is very unlikely, and a complete absence of medical experts or medical people he thinks is impossible. What is exciting to see is that in table 2, that there are already a number of AI approvals given by the FDA. And it's a list of about 15 when this paper was written, but that's now almost 3 years ago. And I presume that the list has gone up to 50 or more. And one of the first ones was the detection of atrial fibrillation using the Apple Watch and, of course, the Apple phone. And that's now an application that millions of people are looking at worldwide. So that's one of the many applications that exist now in the different areas of medicine. But a lot of applications, most of them are actually used by medical experts and in hospitals. There's also an overview and a list of review articles which are listing most of the evidence base that exists so far. So a lot of randomized clinical trials that have been conducted and are being conducted on AI applications in medicine. For instance, there are studies going on in neurology and looking at acute neurological events by Titano and co-workers, published in 2018, looking at rapid diagnosis and treatment of acute neurological illnesses such as stroke and hemorrhage and hydrocephalus. And these are critical to achieving positive outcomes and preserving neurologic function. This was a study that was randomized, prospective, double-blinded on using a 3D convolutional neural network, CNN as it is called, and showing that it was at least as good as the human interface. Another study on melanomas by Hainsel and co-workers, published a year later. It's called Man Against Machine, Diagnostic Performance of a Deep Learning Convolutional Neural Network, also CNN, for dermoscopic melanoma recognition in comparison with 58 dermatologists. And most dermatologists were outperformed by the AI. Not all of them were, but most of them were. So now, some people saying this is fantastic and this is great, and we need to do this more and more. And other people are saying, okay, but you either do it very carefully or you need to really stop it. So there are extreme opinions on both sides. I mean, this is of course normal in medicine, particularly when there is such a huge new development. And we'll see more of this in debates also in our own field, where people will say, well, it either is not really working properly, or it may be too expensive or too cumbersome to put into place, maybe in the embryology lab. And of course, at some point, when you put all these AIs together, there are people postulating that that's potentially dangerous. And so that debate is going on. In the background of this, there are ethical studies being conducted. There are also rules being drawn up by different organizations that look at the ethics of artificial intelligence, and they're particularly looking at 7 core ethics and conduct principles. They're looking at human oversight, that needs to be ingrained in it. It has to be technically robust and safe. There has to be privacy that has to be taken into consideration, transparency, fairness. It has to be inclusive. It has to be for the well-being of individuals, society, and the environment. And there has to be accountability. So certainly AI is not developing in a vacuum. Thank you very much. I hope you will enjoy the rest of this meeting, and I'd like to thank both the I3 and IVF 2.0 teams for their suggestions for this lecture. Thank you.
All right, so that was great. And I do think that we actually do have Dr. Cohen on the line, it looks like, live. Great. It's good to see you, Dr. Cohen.
Good to see you. How are you?
So although it was pre-recorded, at least we get to ask you the live questions. Is that right?
Yes, that's right. If there is a question, yeah.
So if you don't mind, I'm going to kind of jump off of that last point of your slide there with the 7 core ethics for AI. And with the last one with accountability, can we have accountability in artificial intelligence? And, you know, if something happens, whose fault is it? Can we blame the AI, or is that a human error?
It's a combination of both, or at least likely for the next years or next decades. I think it really is a combination of both. It's a great question. I had my own doubts reading those papers and about is all that achievable. I think it's important to frame AI in a number of rules that are setting it in clinical care. If we don't do that, we run into dangerous terrains, particularly if AIs become more complicated, which no doubt they will, where they cover different things, when they actually can really make decisions based on different input in the same disease or of a patient who is confronted with different symptoms. And so I think it is important to come up with rules, but you're quite right. It may not be so easy to put that together and to hold on to these principles, as it is in any other, in healthcare right now. I mean, we do have principles, right? But it's not always easy to stick to them.
We certainly do. And in regards to the fields of medicine, how far behind do you think that our field, assisted reproductive technology, or the REI field is compared to these other fields of medicine that we've all kind of referenced, right? We've referenced them in all of the reviews, the ophthalmology, derm, and all those other specialties. How far behind do you think we actually are?
It's not that much. Really what we're missing is funding in this country, but also in most other countries, even in countries where funding would be possible, like in the UK and maybe Australia. I mean, in those countries, you don't see billions of dollars being billions of whatever coinage they have being spent on reproductive research, and in this case AI. It's just not happening. And so I think funding is what's the reason why we are a few years behind. Now, will we in the future, will we really only just stay a little bit behind? It's certainly possible. I think there's a lot of interest, particularly from private organizations, but little startups will have difficulties funding large clinical trials. And you have to do large clinical trials in order to prove anything. Of course, AI is sitting in a good corner right now, because in a narrow AI, all you need to prove is that you're as good as the human person who's normally doing the test. So yes, you don't really have to prove from the start that you're better, that your AI product is better than what we do. And I think so if we can accomplish something like that study that I showed from 2017 on the breast cancer pathology slides, I think we'll have a good future ahead of us. But yeah, funding is the bottleneck, I think.
Yeah, and a part of it, I do believe, also has to do with the little bit of controversy and ethics behind the field that we're in, right? There's a little bit more controversy in the field that we're in, I believe, than other straightforward subspecialties. Is that right? Yeah,
there is that, and there's the complications that we don't deal with one patient at a time. We deal with two partners, one partner, and then maybe a donor, maybe two donors, maybe gestational carrier. So it's very complicated. And I think all of that is exciting, but it doesn't really help you to design a study easily. Yeah.
Great. So let's see if there are any other questions that we can bring up. Charlie, do you see anything? Olcay?
I think
I think we're probably ready for Gerardo.
All right. Okay, so we're going to move on to Gerardo. I have the pleasure of introducing Gerardo at this point. Gerardo Mendizaba Ruiz has a PhD in computer science from the University of Houston. He is currently a research scientist at the University of Guadalajara in Mexico. His current research interests include artificial intelligence, deep learning, big data, pattern recognition, and computer vision. Moreover, he is the head of product development at IVF 2.0, where he is in charge of kind of conceptualizing and designing AI-based assistants that can enhance the decision-making during the IVF procedure. So we are ready for you, Dr. Ruiz.
Thank you very much for the introduction. Today, I'm going to talk to you about artificial intelligence at work, specifically on how these novel technologies can be used during an IVF procedure. These are my affiliations and conflicts of interest. Well, IVF treatments consist of several procedures where oocytes and spermatozoa are manipulated under controlled environments in a laboratory. The main objective of this is to be able to produce healthy embryos that can be transferred to a future mother. Every one of these steps on the IVF pipeline is crucial to achieve the ultimate goal, and therefore have to be performed in the best possible way. Now, the people who are in charge of successfully performing such procedures are the embryologists, who can also be named as single-cell surgeons. They are responsible not only for doing the manipulation of the cells, but also for taking crucial decisions that can define the success or the failure of an IVF treatment. However, most of these decisions must be taken after a short visual inspection of the cells. And it's short because we have to consider that the time that the cells spend outside incubators have to be minimized to reduce the stress. This represents a great challenge since for humans, as we know, our judgments can be affected by different circumstances, such as fatigue, stress, maybe a bad day, so on, so forth. But, you know, embryologists are not the only specialists who have to take important decisions under difficult circumstances. In other medical fields, medical doctors also face similar challenges. And to overcome them, it is really common that surgeons have human assistants during their interventions who can provide opportune advice. I know some doctors that say that even when they perform, they want the assistant to be an even better surgeon than what they are. So, you know, this is something really common. Moreover, with the advancement of technology, now it is more common to find advanced image devices and computers in the operation rooms. The mission of these devices and computers is to support the surgeon during the surgical procedure by providing valuable and opportune quantitative information. Here we have an example of a catheterism where, you know, we have some 3D reconstruction that the intervention can assess in real time during the procedure, and of course it will help him take better decisions. Now, most of these computer-based tools consist of computer vision algorithms, which can be used to process and analyze image and video streams from these medical image devices, most of them even on real time. But you might ask, why do we need computer vision tools if the human brain is so powerful and we can, you know, as humans, solve really difficult problems? And you're right. However, there are certain types of problems where computers are better than humans. For example, for you, it will be very easy to find the Q's, the only Q among the O's. However, finding the O within the Q's in this image might be a little bit more challenging, but still is possible in a reasonable amount of time, right? Now, let's make it a little bit more difficult. Try to find Waldo in this image. We all realize that this task is more challenging because there are many patterns on this image that might be somehow similar to what we're trying to find. The advantage of computers for this type of problems is that they can examine the whole image and evaluate different regions of it with really great detail, all simultaneously, and in just fractions of seconds. Here's Waldo by it. Modern computer vision algorithms rely on the use of artificial intelligence. The great advantage of AI is its capability of finding and exploring patterns on the data that might not be evident for humans. And it is precisely thanks to this great advantage in AI research that new opportunities arise, and in particular, in this case, for IVF laboratories. And this is especially because the majority of the IVF microscopes in the workstations already have digital cameras. That means that anything that an embryologist can see through the oculars can also be seen by the computer. Therefore, there is no need to buy extra costly equipment. We pretty much have everything that we need right there. These digital cameras in the microscope what they do is pretty much they have the capability of converting the light that comes from the samples, from the cells in the microscope. They convert those to numbers by the use of specially designed semiconductors. And the patterns that emerge from this number can be related with the characteristics of the structures of what is being observed. In this case, in this example, a blastocyst. Then, by applying computer vision and deep learning algorithms, it is possible to extract a variety of features from these images that might be impossible to identify by the human eye. Then these features can be used to generate high-dimensional spaces where the images that correspond to cells that are somehow similar are near each other. And then, if we have labels for these images, for example, something related for the quality of the embryo, such as genetic test or other, we can teach the computer to find patterns in the data that can relate to these labels. For this, what we do is that these features that are extracted are fed to machine learning algorithms, which can generate models that find regions of these spaces that are related to these labels in such a way that the type of an image that has never been observed can be predicted accurately by the model. Some of these AI models can also be used to find relevant regions of interest in a blastocyst among different local planes to generate 3D analysis and 3D reconstruction, making the models more robust. Moreover, in the case of selecting sperms from ICSI, for a human, it will be very difficult to keep track and analyze every single sperm on the field of the microscope. However, computers cannot only track individual cells simultaneously, but they also can find other properties that are not evident for the human eye. Or even, they can perform an automatic analysis of head movement patterns, such as rotation of sperms. And also, like the analysis of the trajectories of the single sperms. Then with all these, the idea is to use these technologies, these technological advances to create artificial intelligence assistants for the IVF labs. And something that is really important is that we have to realize that AI does not intend to replace a human expert, at least not right now. Indeed, what these tools can do is to augment the capability of decision-making by providing opportune valuable information. This is what we call augmented intelligence. And this is something that is already happening in many IVF clinics around the world. For example, for choosing the best embryo to transfer, many clinics are currently using ERICA. ERICA is trained on PGT data, and it provides a ranking of the candidate blastocysts. So pretty much what happened is that embryologists have more information to decide which is going to be the embryo to transfer. And then in other part of the IVF pipeline, for choosing the, there are these are some numbers related to the number of embryos that ERICA have assessed during the last year around the world. So this is something this has been already using. And then in other part of the IVF pipeline, for choosing the best sperm to inject during an ICSI, more recently, some clinics have started using SIT, which is an AI tool that provides real-time analysis and ranking of individual sperm. Let's take a really quick look of how SIT looks. So basically, you put the sperm sample under the inverted microscope, and then you open SIT, you choose to start your ICSI, and then just wait a little bit, 2 seconds for SIT to start analyzing all the sperms, and then it is ready. What you do is that every time you put the needle inside of this circle, it will provide a ranking, telling you what are the best 3 sperms to inject. And then all you have to do is just to verify the morphology and things like that, because SIT right now only use motility patterns. But if you don't like it, you can reassess many times. It's unlimited reassessment. So this way, the embryologists combined with seed, they both can making sure that the sperms that are selected are of the best quality, but also it brings the opportunity to standardize process within the clinics. So far, we know about at least 25 ongoing pregnancies where the injected sperm was selected using seed. We're also performing a prospective study using sibling oocytes. Although the number of cases is still small, we need to gather more data. The results seems to be really promising. Then we believe that there are other procedures in the IVF pipeline for which the use of AI assistant can help embryologists while performing, including this oocyte finding, denudation, sperm injection, so on and so forth, and also for taking decisions such as the best moment to transfer, determine if an oocyte is ready for fertilization, so on, so forth. And one of the most important things is that as long as we can collect more data, these AI models can keep learning from it and then help us to travel the path from data to information, to knowledge, insight, wisdom, and finally being able to make an impact. Well, with this, I finished my presentation, but finally, I would like you to invite you, if you're interested in playing around with Erica, if you want to see how it works, you can, we have developed this mobile app that can be used in any Android or iOS phone or tablet. And you can play against other players and select the best embryo to transfer. If you want to try it, you just have to enter this webpage and then you will find links to download the apps. When you do, the first time that after you install the first time that you enter, you will be asked for a nickname. So you can put anything that you want there, like your favorite name. And then please use this following invitation code. It's i3.invite. And then, well, just start playing and have fun. Thank you very much for your attention.
Thank you so much. That was a fascinating talk, and it's so exciting, some of the work that you guys are doing at IVF 2.0. You've really pushed this along in the field, so congratulations. We have a quick question from Radhika, sorry if I'm mispronouncing your name, from Oslo. When you're selecting human sperm using AI methods, how are you accounting for morphology?
Okay, so this first version of SIT focus more on motility, because we know, and we're doing some studies on that the motility and morphology are really, there's a good relationship between them, right? Like one of the example that we always say that imagine a dog with 3 legs. Of course, a dog with 3 legs is not gonna walk the same as a dog with 4 legs. So what we do right now is that SIT will tell you which are the best sperms considering the motility according to the World Health Organization patterns. You know, in this manual for sperm selection, there are some things that they measure. So we use those metrics for giving the recommendation. But of course, you know, this is an assistant, so embryologists need to still make sure that the morphology of the sperm is good. I mean, this doesn't have to be used blindly. This is an assistant, right? But we, of course, are considering incorporating analysis of morphology on SIT for future versions.
Yeah, you can imagine if you have IMSI technology, the AI would be perfect for, you know, selecting embryo sperm based on morphology.
Yeah,
quite excellent. I'm going to go ahead and move forward. We could ask more questions at the end here, but just to move this along, Alejandro Chavez Badiola is the founder and scientific director at IVF 2.0 UK Ltd, a biotech company committed to the advancement of reproductive medicine, as we see some really beautiful examples just a moment ago. He's a highly qualified obstetrician and a gynecologist, the chief medical officer at the New Hope Fertility in Mexico, and he's currently attending Kent University to complete his PhD studies on what I have to assume is artificial intelligence.
It is. So thank you very much for the introduction and the invitation. And I try to avoid making a presentation after Gerardo because he has so beautiful slides that it's difficult to compete. But the two previous presentations have focused on AI as a tool. And in repeated occasions, it's been stated that AI in its current form is an assistant. And that's very good news. It's not here to replace anyone, it's an assistant. So conflicts of interest have already been described. Mainly, I am a founding partner of IVF 2.0. And again, going back to making up your mind, the question for me is, if AI is a tool that can work as an assistant, I believe that you should ask yourself, do you need an assistant, or who needs an assistant? I believe that the chances of you needing an assistant go up as you have decisions that have high impact on other people, or when your responsibilities, the responsibilities attached to your job are very high. So I couldn't think about an astronaut trying to go to the moon, Mars, anywhere, doing this on their own. Of course, they need assistance. They need a lot of assistance because the stakes are very high. And how about you? Now, of course, not everyone can gain access to very good assistance, and that's crucial. The quality of the assistance available is very important to making a decision about whether you want this assistance or not. And of course, how efficient this assistance is, meaning the cost benefit, how easy it is to interact, how much time is it going to take on top of your daily routines, and the cost to the patient potentially as well. So again, do you need an assistant? You're making decisions every day, several times a day. But the question is, are you making these decisions consistently? At the end, if you perform a procedure one time in your life and you succeed, this doesn't mean that you're going to be 100% accurate. To be very, very good, you need to perform this consistently every time, or at least as consistently as possible, because this consistency has an effect on patients' outcomes. This is, if you're in a bad mood, if you're not performing at your best today, then this could be translated into reduced chances of a pregnancy for a patient. If you think about the IVF lab, the IVF process as a team, then how consistent is the weakest link is as important as how consistent you are. Think about the doctors working in your clinic. Think about the team of embryologists that are working around you. And of course, this is allowing for improved access because every failed treatment is going to be costly to the patient, emotionally, time-wise, financially. And this consistency also is translated into transparency. For you as an embryologist, then how happy are you with the decisions that you're making every day? Wouldn't you use some reassurance? Just think about the need for a double witness, whether it's a physical individual that is next to you performing the double witnessing or an electronic witnessing system. You need reassurance on the decisions that you're making. And you also have to question about how are the processes that you're using, are these designed for efficiency or are these taking more time of you? And of course, you want an assistance to improve your performance and to continue learning. For lab managers who are their job is to drive results, they need to understand the problems so they can systematically approach them and then fine-tune and challenge these problems to improve efficiency. And with efficiency and results comes reputation and costs management. So ask yourself again, how is the IVF process today? Is artisanal? Decisions are mostly made on subjective assessment of cells, of sperm, of embryos. Decisions in the fashion in which are made are prone to error and are very difficult to scale. And not only the decisions, but just think about the shortage of embryologists currently. It's very, very difficult and very long to take a trainee embryologist to the point where they actually can start working with patients. Can AI, can technology help us with this? I believe that yes, that AI can improve the way in which we are assessing cells and the way in which we're making decisions, but by allowing us to quantify everything that we're doing. And in this way, we can standardize, we can offer reassurance to our patients, to ourselves, and in this way, we can drive efficiency and improve outcomes. If you need more examples, take the image of this embryo. Chances are, if you see this embryo in a couple of weeks, you might give it a different classification. And if you ask all the embryologists that are here, chances are they won't agree with your classification. And Charles just published a paper some years ago, a couple of years ago, about how consistent are embryologists when they are classifying embryos. The answer is their consistency ranges from 52 to 58%. That's not very high. Even less if you compare it against AI. So the question is, should we limit our decisions based on conventional features? The image that I'm showing you now is the same embryo. The only difference is that you're looking at it under artificial vision filters. So how many new features can you extract from these images? So how long would it take you to evaluate these embryos? Now for the AI, it's very easy. It's done practically in real time. Another example is sperm selection. So we have found different characteristics of sperm that are related to blastocyst formation. We actually have found motility patterns that have not been described by the WHO manual. Why? Because our eyes are not designed to see these kind of speeds and compare, and computers are. But even if we knew, even if we're given standards, trying to translate these standards into real time is very difficult, not only for morphology. So I heard these questions about morphology. Can you really assess morphology here and speed? And again, embryologists are not that consistent when they are compared against people in the same lab with the same level of expertise and theoretically with the same protocols. But computers are. And two examples are SEED. We just published a paper last month about this sperm identification AI. You have already seen this video probably. And just, I know that this sample is very busy and the sperm are not in PVP, but compare that against this, where you have an AI that is identifying every single sperm under the vision field, tracking it individually, extracting features that are correlated to outcomes defined by normal fertilization and blastocyst formation, and is pointing this at you. So you don't have to worry about the speed and motility patterns. The only thing that you have to focus on is morphology. Now, take a look at this video. The other thing that you will notice is that SEED has a graphic on the top left corner. What it's showing you is not only which is the best sperm in this specific vision field, but how these sperm compare against the sperm that SEED has seen in the same sample in other vision fields. So you see, these are not the best sperm in the sample. Probably you won't even remember the sperm that you saw in the previous vision field. SEED does remember and is comparing these. So even if you have what looks like a good one, and you see in the graphic that there were better ones, you can go back. This is a poor sample. But again, this is a real sample. And every now and then, cases are not perfect. For ERICA, it's pretty much the same. ERICA can identify features that we cannot identify with the naked eye under the microscope. And also, Erika has been trained in a different fashion as embryologists. Embryologists were not trained to identify embryos according to ploidy. Embryologists were trained to classify embryos. And this is why this assistant is so good, because he's approaching the challenge from a different perspective. Now, how good is Erika? Just take a look at this NDCG, which is the correct metric to assess a ranking system. This is how good is the AI to identify euploid embryos on top of the ranking and aneuploid embryos at the bottom of the ranking. You have already seen this, Erika's interface and how it works, and please, you're invited to download and play around with this experience. And the intention with this is for you to start interacting with AI. Because as I mentioned at the very beginning, if your job is making relevant decisions with high impact, you need an assistant. But this assistant should be very good and should be easy to interact with, meaning you need to learn how to interact with it, because machines make mistakes, and so do you. So you have to understand when the machines are making mistakes or when they are most likely to make a mistake, so you can make a decision, overrule the decision or the recommendation of the computer. But the important thing is that when you learn to interact with the computer, it's the combination of the computer plus your experience could be better than either of you working on your own. So I'm going to compare here. This is just an example based on the Erika experience. So we have the U7, the user 7, who was the best performing individual in this setting. And it took this individual almost 1.9 selections before he identified euploid embryos. Now, take a look at the performance of the worst performing individual, who was the user number 6. When using AI, the number of selections needed to identify a euploid embryo was brought down to 1.6, outperforming the best performing individual without the AI. Now, what if we put it a price here? What if we imagine that the cost of an embryo transfer is $3,500 US dollars, pounds, euros, whatever you want? What would be the cost of the best performing individual to transfer one euploid embryo in a cycle when there is at least one euploid embryo? What would be the cost of the worst performing individual? You see, consistency is very important. And when you get an assistant, then you can bring the costs down. Now imagine you have 1,000 cycles. Imagine you multiply this difference, almost 500 per cycle, for 1,000 transfers. Now that does make a difference. And on top of that, you have to think about the time, the emotions that patients go through. So you can put a price on consistency. Also, you have to learn about your assistant, whether this is making decisions based on videos, time-lapse videos, static images, the number of samples that were used for training, but probably as important, what is this AI doing with information that it's receiving? So one example is, of course, having static images and doing not much with them is not of great use. But what if you could try and reconstruct in 3D to extract valuable features? And thinking about transparency for the patients, imagine what you could do to help your patients understand better what the inner cell mass is, the trophectoderm is, and why you think that this embryo that you're about to transfer has a good chance or not such a good chance. So you need to make up your mind. You need an assistant, but you have to remember that machines make mistakes. So do you. You have to learn to work with them. And very, very important, If you are given the opportunity to collaborate and contribute towards building this technology, take the chance. Selection is not enough. We have to make sure that the AI can influence the outcome of the cells that are presented to it. Saying that an egg is good or bad is not enough. We have to make sure that we train the AI to understand when is the best time, let's say, to inject an egg, when is the best time to perform an embryo transfer, a biopsy, or when is the best time to freeze an egg, for example. The examples that we presented are just a few, but if we think about the IVF as a process and we deconstruct this into Lego-like blocks, this is pretty much how it looks in the lab. And we can use assistance in every single step, just for reassurance purposes, just to make us more consistent, probably to help us learn more, and then to improve outcomes. Probably you read this paper, which was just published a couple of weeks ago. And as soon as I did, I went into LinkedIn to see the reactions from people. And this is just a screenshot. So first question is like, fantastic, we need more embryologists. Where are we going to get them from? And then the next answer was, yeah, imagine we get them. How are we going to train them to the highest possible standard? So again, training embryologists is a challenge as well. Making them at the best of their performance is a challenge. But AI can help, and it can help you improve efficiency, standardized practice, give you, your patients, peace of mind, and make the process more transparent. Whether you are an embryologist, a patient, or lab manager, AI can help you. In brief, if your job is a high responsibility one, if the decisions that you're making have high impact, you can use an assistant. You have to make sure that the assistance that you choose is the best quality available and that is efficient so it can help you instead of drag you. So thank you very much. I want to thank the IVF 2.0 team, the team of New Hope in Mexico, and this was my presentation. Thank you.
Alejandro, thank you so very much for the awesome presentation here. I just, real briefly, Larry and Anil, I hope the echo issue, the technical issue has been resolved. So we'll go into asking a few questions. Alejandro, I'll start off, and then maybe Olcay and Lisette can also kind of chip in with some questions. We've got plenty of questions here from around the world. So I'll start off one from the United Kingdom, from where you're at right now locally. So Gulam is asking, the commercial for profit sector will inevitably be looking for staff deployment and reduction. However reassuring you have been with your talk, it's profit over people, he says. So what is the timeline for half the IVF clinics embracing AI technology?
What is the timeline?
So my understanding is, what is the timeline for about 50% of the IVF clinics actually embracing AI in their embryology clinic?
I think that it's very difficult for any technology to become universally adopted. So for 50% of the clinics, I would love to think that 50% of the clinics, at least in Europe, the United States, would be adopting some form of AI, probably within the next 2 years, 50%. Not through the whole process, but probably some for sperm selection, some others for AI, for egg assessment, and some for embryo selection. Some others even for the clinical side, for triggering, for stimulation. But I think that 50%, some form of AI, 2-3 years.
Thanks for that. Olcay, Lisette, do you guys want to kick in?
Sure. There is a question from Francesca Bauer from Life, Denmark. Is AI decision assistance about being better than embryologists who all have their own performance abilities? Or is it about having all embryologists consistently performing as well as highly trained embryologists, but saving time so resources can be used for necessary hands-on procedures?
I think that the second option is spot on. The idea is to make the best use of human resources. Most cases probably are relatively straightforward cases. And there are some edge cases where you need to pay more attention. Unfortunately, with the current workflow, you are allowed to dedicate as much time to the straightforward cases than you do for the edge cases. And again, for the hands-on procedures, well, if you have even junior embryologists with the assistance of AI that can perform at the same level than a senior embryologist, then you have, I mean, what I consider a successful outcome with AI.
I have also a very good question from Nina Alicani. She's asking, like, how does seed functions when a sperm is placed in PVP? And have you accounted for the slowdown and changes in motility patterns of the sperm in a PVP environment?
Yes. What we are developing are ranking systems. This means that the conditions in a given sample are exactly the same for this population of sperm. So if you prepare with 7%, 10% PVP, if you decided to use sperm slow, if all were hyperactivated, it's going to be exactly the same for this population. And what SEED is doing is ranking the best sperm from amongst that population. So yes, the computer can work with that.
A great question from Philip Chan. The AI assistant is really only as good as the teacher. Are there any international standards on the group of people qualified to teach the AI software?
Well, this is partially true, because if at the end you have an outcome and you have a large enough data set, sometimes you don't even need this teacher. So again, this is partially true. Now, for those cases in which human knowledge is being used and human annotations are being used, yes, of course. How good is the individual is of great value. But if the data set is of high value, we need to make sure that everything is evaluated by more than one individual. So there is redundancy. So we can confirm that the training, the opinion, the subjective opinion and assessment from one individual is consistent with more experts in that area. I don't know if that answers the question.
Oh, that makes a lot of sense. Also, we have a great question from Dr. Sakis. How do we distinguish between different AI platforms that are being published right now to select the best embryo for transfer?
The first one is, how do they interact with your lab? So do you need any specific tools? Like, do you need time lapse? Do you need an embryoscope? Do you need a Getty? Or can you use it with your current lab setting? The second question, the second fact that could make a difference is whether this AI is evaluating static images or is using the sequence from the time lapse. And then how is their performance being described? Are they trying to train their AIs to predict a live birth, which is very challenging because, of course, we don't know who is a clinician performing the transfer or the conditions of the environment in which this embryo is going to be transferred. So there are a lot of things that are beyond the comprehension of the computer. So there's margin for mistake. Also, again, so what's the outcome? And also, of course, the architecture, and probably as important, the metrics that are being used to define success. So I was mentioning about the NDCG. So yes, of course, when we published our paper, we are describing AUCs and we're describing accuracy, but the real valuable number is for ranking systems is NDCG. It doesn't matter if the computer thinks that this embryo has a 50% of being euploid or 30%. What is important is that it will give euploid embryos the best chance of appearing on top of the ranking and abnormal embryos to be at the bottom of the ranking. So that's a completely different metric. And that also makes a difference between the available AI systems for embryo selection and ranking.
Thanks, Alejandro. So we're going to include some questions here for Gerardo and Jacques as well, if that's okay. We do have a question here from Canada, from Don Rieger. He's asking, how do the regulatory agencies approve AI, given that it is, by definition, continuously changing? And that was a question for Dr. Cohen. If you are able, and I can repeat the question because I know I caught you off guard there. So the question is, how do the regulatory agencies approve artificial intelligence, given that it is by definition continually changing?
Well, thank you, Irene, and thank you, Don Rieger. It's good to hear from you. Never have an easy question, do you? I would open the panel to answer this particular question. I don't know why it's exactly directed to me, but I did mention the principles, ethics principles that occur. Yeah, truly, that is a huge thing. And I think that's one of the reasons why the FDA is so conservative in approving an AI product and kind of freezing it in time, right? Alejandro, I think they like to freeze the product in time and say, well, if you have an upgrade, come back later, and then that's another application. Rather than, I don't think anybody has been able yet to get a product approved that is already continuously changing and upgrading automatically without going back to the FDA. Don, of course, is an FDA expert too, so he knows very well that you have to stick with the same product. Any change you make, doesn't matter how small it is, you have to go back to the FDA to get another approval. Usually that is a more simpler process, but still time consuming. So I think that's what Don is referring to. I don't know, Alejandro and Gerardo, if you have an input for this, but I think this will be the same as CE marking. It will be the same as the FDA. Yeah.
I think that it's a very challenging subject for regulators. I think that there is a risk that they will decide to regulate according to whatever is easiest to understand. And this would be asking us to present fixed versions of our products. And then if we are updating these to, as you said, resubmit. But I believe that the most challenging, the most difficult, but probably the best approach to do it is to making sure that they evaluate the traceability of the data sets and the process that is leading to this dynamic algorithm. So if they focus their attention on regulating that aspect and making us go through all that process, but if they keep their focus on that part, then this will give us the freedom to keep updating pretty much live if needed algorithms, and in this way improving on behalf of patients. And of course, for us to go through all the quality assurance processes before we release a new version. But I think that would be, from my perspective, the best approach.
I have a question for Gerardo. Should patients have to pay for enhanced decisions, or should it be integrated as part of a new standard of an IVF practice?
Well, I don't know if that's a question for me. Maybe it's more for a clinical IVF director. I will say, from my opinion, is I think that this kind of technology should be in any, in any procedure, because there is a lack of standardization around the industry, and IVF industry, because most of the procedures are performed by people who are taking decision right on the spot, and decisions can be different from one day to the other. So I really believe that IVF could benefit a lot from the standardization that these AI tools can bring. But I don't know, maybe Alejandro wants to add something to this answer.
I have mixed feelings because, of course, I think that on the one hand, the AI is improving outcomes, is standardizing and giving individual patients better chance just by this, making the decisions made on a daily basis more standard. But on the other hand, I think that when things are free, people tend not to value what they have in front of them. And I'm just going to give you an example. At some point, we were using an electronic witnessing system, and patients were losing the cards all the time. And they couldn't care less until we started charging extra for that. Then they were taking care of the cards, and they were asking about the technology. They were actually taking interest in what we were doing differently. The same happened with the AI. We were not charging patients for the AI, and they couldn't care less. They thought that everyone had it, that was standard practice. But when we started charging, once again, they engaged in asking questions and trying to learn a bit more about what we were doing. And I think that is also of great value, patients getting engaged in their treatments. So that's the only benefit I think about charging. The risk, of course, is that HFEA, for example, will consider this as an add-on, and we're charging patients because we want to make more money. So, of course, there will always be debate around this. I don't know, Jack.
Yeah, I think it's a very important ethical question, and it certainly won't be the first time that this is happening, right, Charlie? I think we've had in the past, we've had these what the HFEA calls add-ons, such as assisted hatching, right, 20, 30 years ago. I was astonished people started charging for that. Clinics started charging for that, because I think in the first paper we published, it was clear that the improvement, if anything, was marginal, and that it was only applicable to certain patients. And so why would you charge for that? But yeah, over time, once one clinic starts charging, others follow. And that's a problem. You can't really, I mean, there's so much freedom in medicine that once one clinic charges, we're stuck in this rhythm of charging. I think one more important question is, well, what would you charge? And I think that should be really as minimal as possible. If you compare what's being charged for PGTA, which is of course a very complex procedure, and then for an AI that looks like Erga, that looks at ploidy, I think there should be it doesn't look at ploidy in an exact way. It doesn't approach a PGTA test. It is not the same, but it's being trained that way. So you need to charge something, but it will be a fraction of what the PGTA cost would be. So it's a very difficult question. I wish there were rules for this, and I wish it was, but I think it should be as little as possible.
Thanks for bringing that up, Dr. Cohen, because Gulam from the UK actually had that question exactly, asking about how much do you think it would cost for AI technology to be kind of implemented in the IVF laboratory. So I think that's it's so much in the early stages at this point that it's hard to put a price tag on it at this point.
Well, of course, it does. There is an expense associated with developing this technology. Just to get an FDA permit, as Don Rieger could tell you, it's a very expensive process. So yeah, there has to be some damage involved. But I wish it was integrated in some way in the total package, and certainly clinics could choose for that. If the pricing model, and I'm not saying that this is the pricing model, but if the pricing model is going to be $100 for SIT, let's say, well, why make that extra? Maybe incorporate it. And so I think it's a consideration that needs to be evaluated in setting up the pricing models. Whether it is complicated, there will be a lot more discussion about it. But yeah, I would like to keep it, but that's because I'm an embryologist and maybe not a businessman as much. I like to keep it as affordable as possible. And I think that applies to you as well, Irene, and most people here on the panel.
Gerardo, there was a question from Athens. Dimitra was asking, first of all, was saying that you had a wonderful talk, but have you tried SIT on oligoacidoteratospermia samples?
Yes, we have tried SIT with different qualities of samples, including those that have very poor number of sperms or very poor motility. Dr. Alejandro just showed some videos about that. SID works in most of the cases, except when there's sperms that don't move at all. Right now, SID doesn't detect them, but a future version of SID will be able to do it, because it's a little bit tricky to do it if things are not moving. But yeah, we have tried SID with different microscopes, different magnifications, 20x, 40x, different PVP concentrations, and many different type of samples, like from many different patients.
There is another question for you, Gerardo. Does 3D reconstruction slow down the AI analysis compared to 2D?
Not at all. Like right now, the hardware is on our side, because now we have really powerful computers and these GPUs technologies that can accelerate the inference time using when you're using this kind of algorithm. So I have to say, not really. Like pretty much the same. The only thing is that depending on how you're performing the 3D reconstruction, because right now we're using different focal planes. So if you have something that does that automatically, for example, embryoscopes that take images at different planes, that all we need is the stack of images. If not, you have to do the focal sweep in your microscope while recording the video, but we have ways to extract the important cut from them and then do the reconstruction.
There are also a very good question here for Dr. Alejandro from Denny. He is asking how we can distinguish between the different AI platforms that they are being published to select the best embryo.
I think that is the same question that
we're just talking about
was asked before, but practically main differences are: do you need special equipment for your AI? This is, can you use it with your current lab setting, any microscope, or does it have to work with time lapse, let's say embryoscope, Getty, any other form? The second one is, what is the outcome that the AI is aiming for? Is it live birth? Is it implantation? Which are very, very difficult to assess, because implantation depends on many other things beyond the quality of the embryo. The third one is, what is the metric that this AI is using to measure its performance, and whether that's the correct measure, and whether this is what you need from an assistant. And of course, the size of the data set, the architecture of the AI that was chosen. But to make a decision, I think that the first three are enough. Of course, the cost and how easy the interface is to use.
We have a few more questions, but there's also a comment that I wanted to bring up, because Allison brings up a point about whether or not AI would improve efficiencies in the workflow of a very busy IVF lab. In her kind of mind, or in her logic, she believes it would be an extra step in the process unless there's some sort of replacement of embryo biopsy with artificial intelligence. Would either of the speakers want to kind of address that or make a comment regarding that?
I think that's something that has to be taken care of, because we do know that embryologists are really busy on the lab, so they have to do many things. They have to handle paperwork and then do things with the hands, taking decisions. So our vision in the company is not to put more work on their hands. So that's something that we're working very actively to make our assistants to integrate seamlessly with the IVF pipeline. So I will say that we are trying really hard for that not to happen. We're working for everything to be just there, right? Like a real assistant that is, is behind you, telling you stuff, what they think about what you're doing. This is our goal for products.
Yeah, I want to add some comments. I'm sorry, Irene, to Dr. Gerardo. Just he say, like embryologist, I think I understand that question. Like, it's gonna be extra job in my daily job. So probably in the beginning, yes, we wanna feel it like that because it's part of the learning curve. The same way that we did ICSI, when we learned ICSI, probably when we were injecting 10x was taking us 30, 40 minutes, I don't know, like depending on our training. And now when you have years of experience, it's getting faster. So I feel it's gonna be exactly the same when we implement this artificial intelligence in our daily job.
Yeah, you're totally right. Like the same happens with, for example, Uber, right? The first time you ask for an Uber, you really didn't know what were you doing, but now you don't even think about it. You just press some buttons and that's it. We have that vision. We want the things to be just like that.
Well, I think that's only partially true, Gerardo, because in Uber, there's all these developers that have fixed jobs, and that will make the interface different every week. So every time you go on, you have to think a little bit differently because they have changed the interface. So you're totally right if they just left.
Not Uber.
You're totally right if they left the interface as is. For at least
so Dr.
year.
Cohen, are you promising that the interface of AI when we're implementing it in the lab?
You're so right. You're so right. Gerardo, did you hear this? I mean, this is a very important comment from Irene because we will have that same problem. I've seen these two guys and the others that are involved in IVF 2.0, and they just love to every time come up with a little bit of a new version. So I know this problem is worldwide, and it's just inherent. You have a product, you try to improve it. Yeah.
Yeah, but we do try hard not to, be happy with what we give you.
Yeah.
Alejandro, we had a question. Does it make any difference to Erica whether you have you're using the Gardner scale when you're grading embryos or not?
The Gardner scale is for you. And it's just a tool that you're using to understand the quality of this embryo. Imagine that you are freezing an embryo or a set of embryos, and you don't know if you're going to make the selection in 2 months. So that's just a tool to communicate with the embryologist that is going to make the decision. Now, Erica is another tool that can assist you or other embryologists in making the decision. So you can just skip the Gardner classification. You could do it manually, you could do it in your mind, or not. I mean, you're not annotating this in the Erica platform.
I don't think the intention is to drop the Gardner tool, right? The Gardner classification is great. We know what how good the prognosis is. It's not perfect. There are improvements possible, but I would at this point not encourage skipping it. But you could skip it. But I think it gives you a good, as an embryologist, gives you a good feedback in that you know what it looked like in numbers. It's like a mathematical formula, a tiny little mathematical formula.
It gives you a visual, but in some ways I wish there's a probability for.
Yeah, immediately, well, it's this. Yeah, this is what it looked like. I have a pretty good idea. And so I wouldn't, since it's so easy to do as well, why would you change that? The idea here is to give you an assistant, I think, that maybe can give you an edge. As when you have the Gardner tool and you also do PGTA, it maybe gives you an edge. And so this will be just something else like that. Yeah.
So we're starting to run out of time. So we would like to thank all that took part in this webinar, the sponsors, IVF 2.0, my co-moderator and good friend, Dr. Irene Dimitriadis, the panelists, Olcay Ocali, Giles Palmer, and Elizabeth Barrientos, and the speakers, Jacques Cohen, Alejandro Chavez Badiola, Gerardo Mendizaba Ruiz. And not to forget our team from I3. Thanks for the organizing committee of this initiative, I3, who are Dr. Cohen, Dr. Naji, and then also Dr. Cevites, Thomas Elliott, and Victoria Almela.
Yeah, thank you so very, very much for joining, and join us again soon for another webinar. If you want to follow the website, it's www.ivfmeeting.com, or you can use the web membership app to kind of keep in touch. And don't forget the podcast on the site and wherever you get your podcasts. So our next webinar is on the 7th of September from RBMO. It's Reproduction, Technology, and Society, so please stay tuned. All right, guys, thank you so much for joining us. It was great to be in your company. Bye-bye.
Thank you very much. Bye.
Thank you very